Thank you for inviting me. Rika, thank you. Rika and I have actually been talking about this meeting for years, and so congratulations to everyone who organized it. So I'm going to talk a little bit about a couple topics in rehabilitation, but I'm just going to touch on them because we thought if this talk kind of plants the seed, and then the cases will really operationalize some of the concepts in real life vignettes. And so that's how we're going to kind of play the next hour. So the objectives of this talk, I'm just going to talk about several fundamental concepts, global concepts of pediatric spinal cord injury that I think are really important to remember as we work with kids throughout their lifespan. I'm going to touch upon musculoskeletal health, and then we're going to really dive deep into that in the cases. And I'll talk a little bit about mobility in upper limb. And then I'm going to talk about some of the challenges and opportunities and this concept of why we need to remain pleasantly persistent. And this is really important to me. Mainly, Marika, you did a good job. 25 years ago, there was nothing on spinal cord injury. And we'll look at how much there is on pediatric spinal cord injury today, but we still have to be pleasantly persistent because we're far away of where we need to be. So hopefully that'll come across. So fundamental concepts of pediatric spinal cord injury. We all know what rehabilitation is. And, that's when we teach skills that were once acquired or had. We reteach kids how to do it again after their paralysis. But two really important concepts in pediatric spinal cord injury is this concept of habilitation. And so if a child's injured at 18 months of age, the majority of what we do in pediatric rehabilitation is habilitation. We teach them skills that they never had, whether it's walking, feeding themselves, playing. And so it's important because the way we approach habilitation may be very different from rehabilitation because these kids do not have any mental image of some of the things we're trying to teach them. And then this concept of prehabilitation is also very important in kids with spinal cord injuries because we don't have a linear trajectory, right? So kids with spinal cord injury and their function goes like this, depending on a lot of things. And so we may have a child very young who's in a power wheelchair. Maybe when they go into first grade, they go into a manual wheelchair. And so we have to do some prehabilitation around the upper limbs to get them to propel. And so these may sound simple, but they're quite complex and really important to understand what we're doing when. And it's important to note that they're not siloed. So a lot of times we're doing everything at the same time. So important concepts in pediatrics. Three other words that are really important in kids with spinal cord injury: we want to preserve, we want to promote, and we want to prevent. And we'll talk about some of these concepts throughout the talk and in the cases. And then we also want to anticipate, and we're lucky enough to have data that we can anticipate some things that are going to be down the road. And we should be preparing for them as healthcare systems and really trying to prevent, promote, take care because we anticipate them. And so once you accept a child with a spinal cord injury, it's not a one-time rehab. You follow them over their lifetime. So anticipatory guidance is a concept that came in really pediatrics and primary care, right, Larry? If any of you are parents, when you go into the pediatrics or primary care, they say, okay, you have an 18-month-old, you have safety caps and all your detergent, and if the child's going into middle school, do they wear a helmet? So you're anticipating different things based on the developmental age. And I would argue that we use anticipatory guidance in pediatric spinal cord injury where we should be, because we know about some medical comorbidities and complications. We know that recovery is not linear, and we anticipate kids are going to be functioning here, then they're going to dip, then they're going to go up, and we can anticipate that. We anticipate friends and peers are going to shift in family dynamics, and Kathy's going to talk a little bit about that later. We should also anticipate that parents want access to innovation, and they're going to go through rehabilitation tours. They're going to go anywhere in the world to find what they want for their kids. So we should anticipate that and guide families appropriate. And then we understand that kids will have natural transitions. And I love this picture here, which, kids around middle school, while they can walk, perhaps in braces or with crutches, they typically transition into a wheelchair because they want to be fast. They want to keep up with their peers. And it's not a failure, it's a natural transition. Because it's not always about walking, it's about keeping up with your peers, playing, and participation. And Larry alluded to that. The other concept that's important is kids with spinal cord injury live relatively long lives. So they have longer exposure to secondary conditions, but as important, they have longer exposures to our treatments. So they're on medication longer, they're in PT and OT longer, we're in braces longer. And not only physical complications related to the treatment, there's some psychosocial implications of growing up as a child embedded in the medical system and trying to be fixed. And there's literature on that. And so we have to remember that. Growth and development is directly related to some of these physical complications. Kathy will talk about some of the behavioral and psychosocial implications. And then I think most importantly, this concept of don't expect kids to start here and just move up here. It doesn't happen. And it doesn't happen for a lot of reasons. It has nothing to do with motor level. It has a lot to do with growth and development, natural adolescence, changing environments, changing needs. And we'll talk about that. So just to recap, the concepts: pediatric SCI, rehabilitation, habilitation, and prehabilitation: preserve, promote, prevent, anticipate, longer exposure to secondary complications and our treatments, growth and development, and wearing a nonlinear life. So let me talk quickly a little bit about musculoskeletal health. I'm going to specifically talk about contractures, neuromuscular spine, and neuromuscular hip. Hopefully we'll have a little discussion on bone health in the cases. And Christine, I think you're going to be asked some questions about bone health. But let's talk about upper limb contractures. In adults, we know that at least 60% of adults have forearm and elbow contractures. 50% have wrist and hand contractures. You'll see this pie chart doesn't equal 100 because adults have more than one contracture, but these are the percentages of them. And in kids, we don't know the prevalence, it's unknown. We know that factors that precipitate contractures: spasticity, motor level, flaccidity or lower motor neuron injury, pain, and a fracture. And while the prevalence isn't known in kids, we know it's common. And Squire just came out with this a couple years ago about this complication. So you can see these pictures. What we don't want kids to do is end up in this position with forearm rotation. Wrists are just down here, their fingers are flexed, and they become stuck, because functionally that's really a problem because we function this way. And so the other contracture that is of high risk in kids who are injured as infants at around C6, C7 level injuries, they have these metacarpal phalangeal extension contractures, and we believe it's because of how they use their hands as toddlers. So they're two-handed kids, and so they're always like this. They've got a little bit of finger extension, and then they get stuck. And we see this in these, we see the functional implication, we see the contractures. So what we've always done is during nap and during night, we try to splint them with their forearms pronated, their wrists a little bit flexed, their MCP joints flexed. And we don't want to splint kids all day because we want them to function, but we do want to try to prevent these contractions, again, a concept in SCI. Lower limb contractures, up to 55% of children have hip flexion, knee flexion, and ankle dorsiflexion, likely the way they sit in their wheelchairs most of the day. We know that stretching protocols are ineffective. Our colleague Lisa Harvey in Australia did a lot of studies on this in adults, but concepts pretty similar in kids. Surgical releases have a short-term effect, and we don't know about the sustained stretch with orthotics, insufficient data. I'm going to move on to neuromuscular spine, and appreciate that I'm not saying neuromuscular scoliosis, even though there's scoliosis in here, because a neuromuscular spine is always a combination of scoliosis, rotation, kyphosis. So it's much more complicated than just a scoliosis. But you could see diagnosis, neurological diagnosis in kids. But when you get down to traumatic spinal cord injury, kids under 10 have a 100% chance of developing scoliosis. And these data are from the Scoliosis Research Society in the US. In our work of about 300 kids, we showed that if kids have a spinal cord injury before puberty, 98% will develop a neuromuscular spine, and 67% of those kids go on for a fusion, compared to when they're injured after puberty. A more recent study showed that if children are injured by 14 and a half years of age, it's a prediction of scoliosis within 10 years. So what these data tell us, let me just go back, is that, again, we could use anticipatory guidance based on age at injury to anticipate a neuromuscular spine. So neuromuscular spines are kind of helpful in little kids because they use their collapsed spine and their scoliosis to help with perianal care. Their mouth is closer to their hands, so if they have upper extremity weakness, they could feed themselves. You know, we see these compensatory strategies all the time. The problem is it's progressive. It can cause pressure injuries, thoracic insufficiency syndrome, and some hygiene problems. So what's the management of a neuromuscular spine? Surveillance, watchful waiting, which a lot of programs do. We could use custom molded seating systems or braces to slow the progression, and then spine surgery. So I just want to talk about the TLSO because I don't think there is a consensus on this in terms of, I think orthopedics, like they have a consensus and then rehab people kind of have their own consensus. But if you brace the curve under 20%, again, we anticipate it's going to progress. So we're going to brace it at 20 degrees or under 20 degrees. 50% of those kids may not go on to surgery if you get the brace on before a 20-degree curve. And then it may also delay the time of surgery. So ideally, you want kids to go through their growth spurt before you fuse them because you don't want to fuse a small trunk. And then if you start the TLSO at a curve of 40 degrees or greater, there's little or no effect. So the TLSO, it definitely can improve balance. It helps with power wheelchair control. It helps with respiration. Dependent transfers are easier for the care partner, and it helps with ambulation. However, it interferes with ADLs. If the kids have any muscles in their trunk, we can't really strengthen them. They don't use them. It interferes with manual wheelchair percussion, independent transfers, and reachable workspace. Kids who have hyperhidrosis or live in tropical locations don't tolerate it. And there are risks and nuances, so it can cause pressure injuries. It needs frequent modifications, so you've got to follow these kids every 2 to 3 months, especially when they're on growth spurt. And like Kathy was alluding to, no matter how much you train a parent how to put a child in a car seat and restrain them, no matter how much you train them on how to put on a TLSO, they come in backwards and on incorrectly. So some problems with that. We'll talk more about that when we get to the cases. I'm going to move on to neuromuscular hip. So in order for the femoral, the normal femoral shape and the hip to develop, it requires a normal force environment, the normal physical activity during the greatest period of growth. So that's between 0 and 5, really. And normal physical activity is not analogous to walking. It's crawling, it's rocking, it's rolling. So some people say if we get the kids up walking really, really, really early, as before kids typically walk, maybe we could protect that. The literature shows that it's a combination of all these normal physical activities during the development. So no surprise, again, we can anticipate things that children under 6 have 100% chance of developing a neuromuscular hip. Once they get older, the risk goes down, and it makes sense because the hip is developed. So other risk factors other than age at injury, spasticity and flaccidity. So, both of those are risk factors, sepsis and scoliosis. Complications of a neuromuscular hip, pressure injury, pelvic deformities, scoliosis, increased spasticity, poor sitting balance, and a leg length discrepancy. So there are no consensus or clinical guidelines on hip surveillance in pediatric spinal cord injury. There is in the States, there's a surveillance on the hip in children with cerebral palsy. Likewise, there's no treatment consensus or guidelines on how to manage it. The thinking is manage spasticity, use custom seatings, maybe orthotics, maybe surgery. Sweden was the first country to have a national surveillance of pediatric hip, the paralytic hip. Kids with spinal cord injuries aren't specific, but they're in there, which is fantastic. And so this is something we could really adopt as a field, which is really needed. So a recap on musculoskeletal health. Contractures are common in pediatric spinal cord injury. And again, these concepts of preserve, promote, prevent are really monumental here. Age predicts neuromuscular spine and hip, and we have to use anticipatory guidance and prepare children and families and healthcare providers about this complication. Going to quickly talk about mobility, wheeled and upright, not to be confused with walking. Mobility is a means to get from point A to point B, but it's also a means for children to participate and explore their environment. So it goes beyond walking. It has to be efficient. Children have to be independent. It has to be socially relevant and environmentally appropriate. Really basic concepts of mobility, whether it's upright or wheeled. This is a patient of Larry's, and again, we're on a non-linear trajectory. So at 2 years of age, he's upright in a parapodium and wheeling around. 5 years of age, he's walking with loft strands. 12 years of age, he's in a manual wheelchair. No change in motor level, change in needs and participation in an environment. We have to remember that concept. Let's talk a little bit about wheeled mobility, not to be confused with exercise, right? You need to get to point A and point B, explore our environment, and participate. Children as young as 7 months of age should be considered for power mobility, and there are practice guidelines on that. Now, you don't put a 7-month-old child in a power chair and say, go, because you wouldn't put a 7-month-old who's just learning to walk, go. So there's supervision, there's controls that we could put in place. Seating specifications, you have to consider age, requires frequent modification. We have to look at the musculoskeletal health and the level of injury. Just like the child that I showed before with this nonlinear trajectory, this is Alex, who had birth injury. 2 years of age, he's in a power chair. 5 years of age, when he went to first grade, he's in a manual chair. He's still in a manual chair at 12 years. Then he goes into a power assist at 15 years. At 18 years old, he's in a power chair playing hockey. And then at 21 years of age, he's back in a power assist. No change in motor level, change in participation needs, change in requirements of what he needs it to do every day. And so need to think about that. This is the only study I have on walking. Very important. Parents want their kids to walk. Our studies are low-level designs, high risk of bias. We have no studies sustained through puberty. And all of the literature does show that there's a natural progression to wheeled mobility. So with some of the neuromodulation and some of the FES technologies, I think we have a lot to look forward to in terms of walking. This slide looks really confusing, but I'm jumping into the upper limb, and the upper limb is pretty easy in terms of an algorithm, and this is based in the adult literature, but used routinely with kids. So if you have a C1 to C4 level spinal cord injury, the options are all in blue, which is really environmental control units, different control sources. If you have a C5, C6, C7, or C8 level injury, you can use a combination of orthotics, FES technologies, and all of those injury levels are also eligible or candidates for nerve transfers and tendon transfers. And so there's a nice algorithm published in both adult and pediatric literature to guide us in our thinking. In terms of functional electrical stimulation and maybe the neuromodulation talk this afternoon, we'll get into some of this, I don't know, but there's literature that in kids, it improves efficiency, strength, provides superior function, and kids have greater confidence in it. We need to anticipate technologies like FES are going to continue to develop for kids. And so I just want the therapist to consider we always teach kids how to balance so that they can function, right? So they may hook their arm like the low picture. We may hook back like this. We always lean. And these arrows are showing where these kids repetitively lean and use their compensatory strategy for balance. And I'm just questioning whether we are preserving our lower motor neuron integrity or recalling, causing some peripheral nerve damage if we're continuously using the same compensatory strategy. So the message here is we need to teach kids compensatory strategies. We can't wait for FES, but we could show them a variety so they're not always using the same compensatory strategy and using, pressing on the same nerve. We want to preserve so that we could promote function with future technology. Adaptive equipment, we need to do this very early, even in our littlest infants. So the concepts are identical to adults. We just have to think about the weight, the material, and growth. And so you can make everything we have in adults and you could customize it for kids, and it's very easy. And this just shows a couple examples of biscuits and bottles, etc. I'm not going to get into upper limb reconstruction, but unfortunately, this is underutilized in kids with spinal cord injury, and there really are home runs with this. But tendon transfers and nerve transfers, kind of different concepts, but they're often done in combination. And I just want to point out that in kids with C5 level spinal cord injuries, if you do upper limb reconstruction, it increases independence. They can do more diversified activities, but many of them will remain what I call obligatory two-handed people. So they still need their two hands working together. However, if you do tendon transfers and nerve transfers in kids with C6 injuries, we definitely reduce the amount of adaptive equipment. Life becomes much more spontaneous because they don't have to don all this equipment. But most importantly, perhaps it reestablishes bilateral and unilateral hand function so they could use their hands independent, which is fantastic. They should be done as early as possible, nerve transfers, and we've done tendon transfers in children, around 4 and 5 years of age when they're ready to participate in post-tendon transfer rehabilitation. So just a quick recap, mobility, not to be confused with walking. It has to be purposeful, efficient, nonlinear transitions, frequent changes. Power mobility is appropriate around 7 months of age, considering cognition. Upper limb, very similar to adults. We need to make custom equipment for our youngest. Size, weight, and material matters. We have existing algorithms that we could use, and surgical reconstructions well established. So I have a couple more slides, and this is what I'm going to end with. And when I was putting this slide together, this actually happened. I was asked to be on a phone call by Christopher and Dana Reeves Foundation. And a mom wanted to meet with me. And the mom wanted to know what we've been doing in pediatric spinal cord injury. Her child was injured 3 years ago, child's 7 years old. Very intelligent woman, very frustrated with us. And she basically said that to me. I said, well, have you checked out the leading centers in this country? Some of you are here that I've referred them to. Yep, been there. We want to prevent, we want to promote, we anticipate, the whole deal. School, friends, child happy, function and recovery, a little bit different. Had a long conversation. This is how it went. That's all you got for me? I've been to all those places. They're really nice people. I don't want to travel 3 hours just to exercise all day. I don't see any point to that. This is, and I can't say the words out loud what she said. This is blah, 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 all you have done. What about my child walking? What about my child playing soccer? And not adaptive sports, MJ, soccer. And what about that cure? And this was more Chicago. So yes. Anyway, so I was like, I've been in this for 30 years, and I'm like, okay, I know we've done something. I hope we've done something. I love spinal cord injury. I hope I did something in 30 years, all of us. So, I thought about it. We have clinical trial outcomes that are used in adults that many of us in this room have worked together to validate. And because of those studies that we've done as a group, there is an opportunity to include children and adolescents now in clinical trials. And in fact, they are being included in clinical trials now. We've also taken the SCI standard database, right, the minimal data sets, and we've validated them in kids and made them relevant for kids. And so this has given us an opportunity to harmonize all the clinical data everyone collects in this room as part of standard of care. We could harmonize it and we could know more. That's powerful. And then I just did a PubMed search. When I started out, you could not find one article on pediatric spinal cord injury. And all of a sudden, like I just did this a couple weeks ago, and this is just 2025, like the last 6 months. And there's tons, and it's not just all of us in the room, it's like a lot of different groups are publishing. So there's a lot of people in this space. And what this allows us to do is synthesize those data and really come up with clinical guidelines that help us inform practice. And so I'm thinking, we've done a lot. And then we have the STEEL conference. We have the Pan-European Pediatric Collaboration, which has been amazing, and it has really published important work. And so a lot has happened over the last couple decades, but this wonderful mother who has the best interest for her child thinks not. So why do we have to remain pleasantly persistent? It would be easy for me to just say to this mom, well, you have no clue what you're talking about. We've done a lot. But she has a lot of clue what she's talking about. And so uptake is so slow, like we're really not using the clinical outcome assessments. We haven't harmonized our data, although we have the ability to. We have evidence-based interventions that we're not offering kids. And so Ray Yonder's going to be talking about amazing stuff, the tendon transfer. There's a lot, power mobility in little babies. There's clinical practice guidelines that we're not following, which is okay, I guess, but also, there's barriers to well-designed power studies. And so we don't have an international pediatric EMSCI registry or US model systems. We could, we don't. Money and retention isn't available to watch kids through puberty unless you're in a very endowed environment, which many of us are not. And unfortunately for us, fortunately for kids, there's low numbers of kids with spinal cord injury and poor access. And so this paper that was published in 2017 in the US, only 20% of US children are treated in pediatric centers, kids with spinal cord injury. Of the 445 hospitals that said they treated kids with spinal cord injury, 68% said on average they only see one kid every 3 years. You can't develop expertise, and you can't run a clinical trial, and you can't invest in that hospital if you're the PI if they only are going to contribute one child every 3 years. And then less than a third of children with spinal cord injury are eligible for clinical trials because of a lot of other problems that they have. And so we have a challenge as a group. I mean, we need to rethink about how we're going to collect and learn about pediatric spinal cord injury. However, the reason to remain pleasantly persistent is because we're going to see more kids with spinal cord injury. We've come a long way, and we now have a lot more people in this space, a lot more disciplines in the space, and a lot more intelligence, especially the next generation who has a lot more energy. And so I'm hopeful that we all remain pleasantly persistent so we can improve. Yeah. All I have.